both the things that you've said and people in this room and elsewhere. I totally agree with you about recognising the context of getting a phone call out of the blue and just negotiating, is this a good time, are you the right person? And I think that's really important. I loved what you said about sometimes you don't do it in one conversation. You fire what I would call fire a warning shot. And it might require several conversations with people there. So I think that's really important. And it's okay to decide to start early the conversation. If you know it's going to take time, just recognise that your first conversation is not about sealing the deal, it's about preparing the way. I think the other thing is that one of the things that I think was done fantastically well over COVID, one of the many things that were done fantastically well, and ITU obviously did so many of the had so many of the most difficult, challenging conversations, was that you learn to have these conversations and not to shy away from them and do them as some of them remarkably well. But now you don't have to do them over the phone. You can say, when you say, I want to meet the family, I want to have a conversation with the family, you can say, I wonder whether you want to have this conversation over the phone or whether you want to bring me. We're not quite in the same position as we were in COVID, where you couldn't have anybody in the building. Now you can. And the reason I say that is, I mean, we're all having a virtual conversation over this conference call, and I can't tell, I can see the top of Hira Razak's eyes, but actually anybody else, you know, you cannot really understand how your conversation is landing. And we are human beings that use our eyes and our ears and our emotional intelligence. And you cut that off from yourselves by doing the conversation, a difficult conversation over the phone. You can't show your true empathy and your compassion as well over the phone, because you can't respond to and use the strength of your being a human being and working in a human context. So you don't have to have these conversations over the phone. I think is that right, Mike, at the moment?
Yeah.
That may all change. Let's hope it never does change again. But you can choose to say and negotiate with you to come in, because I think we've got some really important conversations to have. And then the other thing that I think Mike alluded to, and perhaps I'm jumping ahead, but I think there's something about the end of the conversation, which is saying, obviously we've had some difficult conversations here. I wonder about who else in your family would want to be involved in or know about this. And are you okay negotiating? Are they okay to have that conversation? Because they might say, well, I'm only just the youngest son, and there's a son who's very important, or there's a husband, or there's a demented wife, or whatever, and actually I don't know how I'm going to tell them this. So actually part of it is also helping them think about how on earth are they going to deal with whatever you told them. I think that's also part of the closure of your conversation.
Yeah.
Now, I'm not an ITU consultant, and I don't have a lot of experience, although I have been on ITU and done some of these conversations. But what I'm going to talk about here is just some thoughts that might be helpful from other settings in medicine that I think may help you in ITU, or if you're in a training post that actually just puts you in ITU for now, that may take you into any other branch of medicine that you could use elsewhere. And it's a tool based on, I think some of you may have heard of a chap called Atul Gawande. If you have not heard of him and you love really good books, read his book, Being Immortal. It's one of the most, it's written by him, who is a surgeon, remarkably, in America. He was a Harvard scholar. He was Bill Clinton's educational advisor. But he's written some of the most amazing books, beautifully written. And it was an Amazon top seller. It wasn't just for doctors, about some of this. And I've taken some of his work and turned it into a simple tool that I think may be an offering that you might find helpful, but you can tell me whether it is helpful or not at the end, or perhaps in a few weeks' time. So if we go on to some of the information you're providing is going to be difficult, and it's a lot harder to do over the phone. Next slide, please. You are skilled. Do not forget you are skilled. do not forget that just because you're going to a teaching session whereby we say it's hard doesn't mean that you haven't got lots of skills. And I heard some beautiful stuff being talked about by two people in this room, and I'm sure they represent everybody else on this, that there are things that you do well. The beautiful thing about, I'd be thinking about what I would want to know if it was my mother, my husband, my grandmother, my relative in ITU, that grounds to ground you and remember that actually you're talking to people, you're not talking to fodder. But there are things that are difficult. What are the emotions that we find difficult to respond to? Think of the emotions that we find difficult to respond to. Anger, denial.
I said anger. Yeah.
Anger and denial. What sort of emotions?
Challenging, like sitting in this case of like a earlier discussion, they get like a whole kind of thing.
Hope. So hope is a difficult. If it's unrealistic, I think comes back to your point. I'm going to try and repeat because I'm not sure what's being heard. So if you can't hear, please let us know. I don't want to have just the conversation in this room. But we've heard of anger, we've heard of denial, we've heard of unrealistic hope. Any other emotions? Disappointment. What do you mean by disappointment?
When you want to tell them what they will but you know, not very realistic.
So what's the emotion?
They're disappointed with what?
So upset.
Yeah.
Upset. Tears. How good are we at tears?
Push the tissue box over.
We push the tissue box over. Why do we push the tissue box over?
Because it deals with the problem.
Because we've actually said be British,
Yeah,
stop crying.
Yeah.
But actually, that's us trying to make the difficult emotion, which I'm going to stress is probably a bit stronger than disappointment. It's actually real sadness, real distress. It's that makes these conversations really difficult. Anger is really difficult. Yeah. Okay, so let's move on. So we talked about the emotions that people may have. If you ring up and speak to, out of the blue, you ring up and say, hi, I'm from ITU at Northwick Park. Can I have a conversation? What are the emotions that the family might be feeling? Fear. Fear is probably the first one. Yeah.
Is this a first time conversation?
Say that again.
Is this the first time we've contacted the family and the patient to come to ITU?
Why do you ask that? Do you think it might differ?
I think so. I think the first conversation is quite difficult, especially if they don't expect it or they didn't know the patient was in the hospital or he deteriorated that quickly. I think that would have a huge impact as opposed to, you know, a sort of update along the line. Yeah. So I think you're right. I'm guessing because I don't work in your context, but you know, the first conversation, hi, I'm Ian from ITU. I'd tell you that they've been moved to ITU because they may not even know. That would be, hang on, that would be very fearful. But even the first time, because they just don't know the sort of reasons that ITU ring, and is it routine to ring, or actually you about to tell me something really serious? But equally, even if I suspect that even if they themselves have seen that the patient hasn't been getting, or they've been getting information from nurses that the patient's still stable, shall we say, and they get a phone call, I suspect even that may be an element of anxiety provoking. And so that's probably quite important to also realise that, because that might also, that there's a strong relationship between the fear, you know, and anger. So it's probably worth recognising straight away and just saying, by the way, you know, is it convenient? I haven't got anything immediate. Your family, your member of family is fine. They are still on the machine and that the other, but I thought it would be helpful. Immediately, that might do something to lessen the emotional response of getting a phone call out of the blue, somebody they've never met and they can't see. They can't gauge your body language at all. And whatever the conversation is, it's worth just noticing that. Glad you just come back, Mike, because I was about to ask you to move on to the next slide. So, shock. Are they giving up? Why are they giving up? There might be an element that they don't care, because again, they've lost the ability to see your compassion. They've lost the ability to see that you care
and the strengths that you've got. And also, they don't know if they come from a particular culture or faith, whether you understand it or even know it. You know, there's a cue here that you have a strong faith. There's a cue here about people's ethnicity. Over the phone, I would not have any of that. And they don't know that. And they might even be as angry and start thinking, especially if there are reasons of, you know, inverse care law and that they start feeling you're making decisions based on race.
Previous experiences.
Previous experience, absolutely. So there's something about just recognizing where the patient's family is when they get this phone call. Okay, next slide, please, Mike. When I first started thinking about this and preparing this tool, I was preparing a talk for the acute care physicians, and I came across this guy who I've never heard of. You may have heard of him. Who's a 13th century Muslim scholar in Persia called Rumi. Is he famous? Right, so I'm getting a nod that he's a famous Islamic scholar. But he said something profound that I think is really profound for all of us. It's not just Islamic. I think there's a message for all of us. The message behind the words is the voice of the heart. And I think sometimes in medicine, we're so keen to end up with the decision, resuscitation, withdrawal, anything that's difficult. We forget that the way we present it tells about the voice of the heart. It tells people that we are compassionate. So I'm going to try and help you synthesize both the voice of the heart and the voice of the brain, which is what we go into those conversations with. The voice of the brain, there's a job I need to do. The consultants told me I need to ring the family to tell them, whatever it may be. It was right to ensure that we're clear what that message is. Next slide, please. So here's my offering to you. The voice of my heart through the 4 Ws plus 1. Okay, so Mike, next slide. So the first W is I wish. If you are having a conversation with a patient's relative over the phone, what might you put into the I wish? I wish your husband could get better. What else? Doesn't matter. Any I wishes. I wish
we could have this conversation in person.
Lovely, beautiful. That's a voice of the heart. Yeah.
I wish I had more information at this time.
Say that again.
I wish I had more information at this time.
I wish I had more information. Why would you be ringing if you haven't got more information? But
No,
yes.
as in if they ask you questions and you can't answer them because
Okay.
you don't.
But I'm
I
saying
think that's
as your first line. So you
Oh,
don't
your
yet
first
know
line. No, I see what you
that
mean.
whether you've got any more information, but you might come back to that, which again is the voice of your heart. Lovely. Yeah, I wish we could have this in conversation. I wish I could be ready to tell you some good news. I wish I could tell you that the oxygen requirement or the ventilatory requirement or the renal failure was getting better. I really wish I could tell you that, because that's what you as doctors want to do. It really is what you want to do. It is your wish. However, I worry. What are the things that have made you worry about a patient? What are the things that you might be worrying about that's led to this conversation? Not improving. Lovely.
Deteriorating.
He's deteriorating, so he's actually getting worse. Lovely.
Not responding. I worry that they're not responding.
Lovely. He's not responding to whatever treatment. It might be a reduction in the ventilation. It might be, what things might he not be responding to?
Stimulation of trying to wake them up.
Stimulation, the waking them up, the antibiotics, the CRP's going up, the dialysis and the renal failure is you're having to dialyse more often, or whatever you do in ITU, forgive my ignorance. Yeah. Yeah, sorry, Mike. But you've got things that you worry about. If you articulate that, I wish I could tell you that he was getting better. I wish that after 3 weeks in ITU, I was able to say I can see a distinct improvement. But I worry that what we're seeing is a patient who's not getting better, a patient who's actually deteriorating, a patient who's not responding as I would hope. And so you get to the third W. So I wonder whether we need to be having a bit more of a conversation about what we should be doing going forward. What that allows the person to do by saying, I wonder, is you're not barging in with, so come on, we need to do DNA CPR. Because the person might say, oh my God, can I just stop you? I'm not the right person to have. I need to have my siblings on the call. I wonder whether you'd like to have this in face to face. All those things are still a bit an opportunity to negotiate the better way of doing it, and for them to say, yeah, I'm into this. And then you've got the fourth W. What would matter to your mum and dad? Knowing that I'm worried about what I'm worried about. So I'm worried that he may not be deteriorating. I'm worried he could be now sick enough to die. There's another great, those of you who like reading, there's another great author called Catherine Mannix, who's written fantastic books, and she uses the saying, sick enough to die. And I think it's a lovely saying. It's not saying they're dying, but yes, they are sick enough to die. What would matter to him on that? You've shown compassion, but you've shown the professionalism of the need to have a serious conversation. What might matter to you, your parents, your grandparents, if you had this conversation? What things might matter to people?
Be comfortable.
Being comfortable. Religious things, yes.
That's that you don't come home with profound disability.
Lovely. That please, if he's not going to recover, he wouldn't want to be kept alive or something like that. Yeah, lovely. Would want to go home with profound disability. What else might matter to people?
That the medical staff are trying their best.
Yes. And notice what you did there, which is what Mike said earlier. You're doing something positive. Not medical staff are just neglecting.
You taught me everything I know.
Right, well done, Mike. You've got a fan here, Mike. I'm not going to tell you who said that, because otherwise you'll write a good review.
It's all right. I recognise the voice. He's already got the brownie point.
Right. It might matter to them. Is he comfortable? Is his family? Can we visit? His son's in Australia. Should he be coming over? Those are the sorts of things that that might matter to them. So if you know what things matter to him, remember what Mike just said, +1. Identify how you might deliver the +1. So what sort of things might you be doing that you don't even notice you're doing in ITU to achieve those things? What are the actions that you might then be offering? So you might be offering increased visiting. Yeah, what else?
As more updates and then
We might,
face to face.
yes, face to face, coming in. I'll ring you again tomorrow so let you know, so that we're showing you that we're actually compassionate and caring.
Specialist nurse advice or help
Which sort of specialist nurse?
if like the retaliation is now.
So if they say that, what matters is, can you ensure that is he in pain, or he would really not want to be in pain? I can get our palliative care team to help us to ensure that we get the best advice on. If it's religion, does he have a priest? Are there prayers? Would he want to have somebody playing recording of the Quran? Does he want to have Bhajan for an Asian patient? A priest or a rabbi? Would he want to be at home? Actually, he wouldn't want to die with all these tubes in. All of the things that you might then do in order to achieve what the fourth W, what matters to you. Have you noticed that I have not yet talked about my agenda? What was the agenda that you said was all difficult? DNA CPR, withdrawal. I haven't talked about those yet, because as Mike pointed out earlier, those are the things that you're not going to do. Those are things that, by and large, are medical decisions. But if you know what you're trying to achieve, you can then say, so what that means is, now we know what's important, it would be appropriate to perhaps continue the antibiotics for another 3 days, or ECMO, or whatever it is you're doing for another period of time. Or actually, at this point, I think now what we need to be doing is prioritising these, so we won't resuscitate, we'll start to wean off the ventilator, we'll get him into a side room, we'll get him onto the wall. You're turning them into enablers of what they want, as opposed to withdrawal of something that they don't understand. I'm going to just, so you've got the 4 W's, the +1, and only at the end, you do the -1. What you're going to withdraw, what you're going to hold. Then you summarise, as I've heard, really what's important to you. Let's make sure that we achieve all of them. But reminding them and stressing the positive. Next slide, please, Mike.
Before I go on, can I just make a suggestion?
Yes, please.
We'll take a quick photo of that slide, because when Charles explained this tool to me a few weeks ago, I thought it was a really good idea and I wanted to use it. And I could not for the life of me remember all of the W's in the right order at the right time.
I'll just send it on the WhatsApp group.
Great, thanks, AJ. And I think the other thing that I just sort of point out is that when I sort of started to use this tool in anger, as it were, what I found really helpful was the fact that it's not a kind of a one-way street. You can circle around with these same kind of concepts as new concerns come up, as new subjects come up. You can circle back using that same sort of language to get you to the place that you want to go. So sorry to interrupt, Charles, but
No, not at all. Right, move on. Next slide, Mike. Right. Who would one of you just like to have a go at if you were trying to use it? The best way to cement a skill is to say, well, let me have a go, see what it would feel like. And you can think of a patient that you've just looked after where you've had a difficult conversation. So you apply literally the patient scenarios in your head and say, yeah, actually, let me just check if it would work. The best way to know if this is going to work in ITU, and I don't work in ITU, is to think of an ITU scenario and see, would it work? Is anybody brave enough? We don't have to do this. Otherwise, I could even let Mike have a go if nobody else wants to. Then we could really see the maestro in action.
well, what I was going to suggest was that I could play the family member on the end of the phone. And I've got a scenario in mind, which I think sort of covers quite a lot of this quite nicely. And some of you might remember, a couple of weeks ago, we had a gentleman who came into the hospital after a first fit and a drop in his consciousness level, who we subsequently found had a horrendous posterior circulation stroke, which had left him with infarcts of his thalamus and much of his brainstem. And it took us about 6 days to find any next of kin for him. But when we did find them, they turned out to be a lovely family who'd been worried sick about him. They lived in Kent. They were coming from a long way away to find out what was going on with him. And we actually went down the route of potential organ donation before he then actually started to unexpectedly make a little bit of improvement. But that scenario sort of that encompasses that sort of first conversation element that I think someone mentioned earlier on. And it sort of means that, and actually this family had a very sort of strong Christian background to them as well. I think one of the siblings was a Christian evangelical minister. And so there's quite a lot of elements to it. And if someone would like to have a go at being the ICU doctor, I'll have a go at being the family.
Mike, can I, if nobody volunteers, I might have an alternative, not scenario, but way of doing it. Let's just see if anybody wants to volunteer. Oh, we've got, I don't know your name. Fatima. Fatima's willing to give it a go, Mike.
Great.
Would you look after this patient? Right. Are you happy to, Mike, what's the bad news that you want Fatima to, at what point is she picking up the phone?
So
finishing your consult ward round and you're saying to Fatima, I want you to ring.
Yeah. So let's do it as first contact. let's go from, we are now about a week into this gentleman's admission, but the family have only just, this is the first time that the family have been contacted by the hospital. We found their details, but they haven't known that this person was unwell. They just knew that they'd been out of contact for a week or so.
And what treatment decisions, Mike? Are there any? Is this just an informing, or are you asking Fatima to gain consent or to help make some treatment decisions in this first conversation?
So in this first conversation, it's mainly about information.
Lovely. So this.
However,
So this is actually the early scenario. This is the firing a warning shot.
Yeah.
To sum up, he had a seizure. He is intubated and ventilated.
That's right.
And okay, on vasopressor support. Any other sepsis, infection?
So early signs of a chest infection on treatment with antibiotics.
And he is stable, or?
He is, yeah.
So this is, I think this is for this conversation, we just want you to not go into the medical detail too much. We just want you to practice a bit about starting the conversation and breaking the and you may not need to do too much of the 4Ws+1 because you're not really breaking any bad news here. This is probably the early. Then I think we might end up with a second conversation a few days later or a few weeks later when he's doing, and we'll carry on with the second conversation, which might be more useful for the talk. But start off with just hi.
Hello, my name is Fatima. I'm one of the doctors calling from Norfolk Park Hospital.
Hello, Fatima.
Hello.
My name's Edward. Can I help?
Yes. Can I you are Edward. Can I have your last name, please?
Sure. Edward Jones.
Calling regarding Mr. Jones. He is one of our patients. We believe you are his brother.
Yes, that's right. Right. So sorry, you've got Andrew with you in intensive care, did you say?
Yes, unfortunately. I'm not sure if you are aware of this, that he is in hospital.
So no, actually, we've been aware that he's not been in contact with any members of the family for a little while, but that's not that unusual for him. So I don't think anyone was too worried. When did he come into hospital, Fatima?
Well, unfortunately, he's been with us for a week now. We have been trying to get to any of his family members, but it's only today we managed to get the details.
Oh,
I'm really sorry to call you and to bring this to you like this.
I'm very glad that you have called. So he's in intensive care. What's happened to him?
So I believe he had a seizure a week ago, and unfortunately we had to put him to sleep, and he is asleep and having some tubes helping him with respiration.
Okay, but it's just a seizure, is it? From what you said.
It's a seizure, and he's having also a chest infection.
Okay, but he's going to be okay.
Well, actually, it's a bit hard to say. Currently, we had to put him to sleep. We are we're helping him to breathe, putting him on machines. We're treating him with antibiotics. He is stable, but it's a critical condition.
Okay, so when will you know when he's going to get better then? When do the antibiotics sort of work by?
Well, we're monitoring, doing bloods every day. The bloods and all his observations seem stable at the time being.
Okay.
Mike, can I stop now? Only because of time.
Yeah.
I'm going to ask Fatima's colleagues, what did they like about what Fatima did?
Gentle. Machine gun with information. And she would give a single statement and let it sink in, a single statement, let it sink in. And that made for a dialogue as opposed to a monologue.
Can I just support that? That was beautiful, Fatima. What you did, technically people call it chopping and chunking. That one of the things that we do when we're nervous, and people talked about being nervous about ringing families, is that we just speak endlessly, and you didn't do that. you actually chopped and chunked it, and you could then let Mike do his thinking and processing, and you learnt an awful lot, much more about how Mike is responding to this because you did that. It was beautiful. What other things did people like about what Fatima did?
Established early on how much, I mean, this knows he knew nothing, but she established
Yeah.
kind of how much he already knows. He knows he's in hospital before kind of giving any information.
Yes. That's what. How did you think it went?
I mean, he had a calm response to me, so that's made me a bit more reassured to go deeper in the conversation. So I think it was well from getting and shouting,
Yeah.
didn't cry or anything.
And let's ask Edward, not Mike. Edward, how did it feel, Edward?
Well, it was good because you know, I was in the middle of the gardening, and I hadn't been thinking about my brother at all, so it was kind of news completely out of the blue. But fortunately, there wasn't kind of too much information for me to sort of not be able to sort of process. It was given to me in such a way that I could kind of get my head around it, and I could think about it, and I could ask some questions, so that when I put my phone down to Fatima, the next thing I was going to call was the rest of his 6 siblings, and I think I'd be able to give that information to them. It wasn't too technical, it wasn't too much.
Lovely. One of the because we've set it up as a scenario, we obviously we didn't ask you to, but you would have checked that it really was Edward, and that it was a convenient time to talk. And obviously getting a phone call out of the blue from a hospital is not easy. Apologies, and also that. Those are sort of the technical things, but what you did lovely. What do we know about Edward and I can't remember your name? Goose. Goose made a comment earlier about this may be the start of preparing the way. What do we know about Edward in terms of how he may respond if we have to sadly tell him bad news in the future? What do we know already?
So he's a priest.
Well, we've heard from Mike that Edward is a priest, but actually from the conversation that you had with him.
And a warning shot, knowing
And
that.
how did he respond? Shocked. What did he say? Remember. What's the emotion or what's the feeling that Edward has got?
Surprise, like, oh,
He's surprised. Is he expecting bad news? How do you know he's not expecting bad news? When's he going to get better? When will we know when he's going to get better? You heard that, didn't you? Yeah, Mike, what's Edward's feeling here?
So Edward is assuming that intensive care is where people go to get treatment to get better. That it's just a matter of time. You've mentioned a number of different things that you're doing to help him get better, and I assume that they're just going to take some time to work.
Lovely. So Goose, you're right. This man, if you start to give him bad news now, he would be a million miles away from being ready, wouldn't he? So, but you now are going in when the consultant, 48 hours time, we're going to now roll it forward, 48 hours. What happens, Mike, that you're now worried? That you're now telling Fatima, or we could choose somebody else. We'll see if anybody else wants to have a go. Whoever's going to have a go, what's changed that you're now telling the SHO to ring up, and what do you want them to say?
So now Andrew has been off sedation for more than 48 hours and is not waking up at all. He's not triggering the ventilator. He's got no signs of any activity in any of his cranial nerves. And we are concerned that the stroke that he has had is not going to be survivable. Indeed, the stroke team have reviewed him and say that this stroke is not compatible with life.
Lovely. So, another volunteer, it could be Fatima. If anybody else wants to volunteer, you're now doing the second conversation to the same relative. And Ed, if you're happy to be Ed.
Yeah, absolutely.
Anybody want to have a go? Yeah,
Unless you want to, do you want to?
let somebody else have a go. I suspect you can do it. It's just about giving somebody else a chance, if that's okay. I'm pretty sure you can do it. What's your name?
Ajay.
Ajay. Lovely. Ajay's going to do it, Mike.
Okay.
And you're on trial here because you've taught him everything you know.
Absolutely. Yeah, this is getting
Actually,
better,
to
isn't
be
it?
fair, this is not us judging Ajay. We're not going to judge Ajay. He's got his what's it called? Aid memoir there if he needs it. He's got that there if he needs it. And we're going to notice and help him to practice it. And like any tool, whether it's riding a bike or anything else, he's just getting an opportunity to practice it in a safe way. But we're not, and when we finish, we do the same thing. What went well? What did we like? Anything that AJ or Edward or us could say would be even better. Yep. Okay, so do you want to make a call to Edward? Do you clear anything you want to know?
So just to recap, catastrophic stroke, unsurvivable, dependent on the ventilator, and the neurology is getting worse and worse. And in fact, there's next to no response.
Yep.
The stroke team are in agreement that this is unsurvivable, and I'm calling Edward again to update and just get their ideas.
Lovely. And from what you know, what sort of response are you going to get from Ed?
Perhaps denial, perhaps unrealistic hope.
Lovely. So the tool here is to recognise that. Mike, don't make it too difficult because I don't want him to be, so, if you think about what's the tool that Edward really needs in order to understand it, once you hear that, let go. Don't make it so extreme that AJ really can't bail out. We want to make it helpful.
Yeah.
Hello, is that Edward? Can I confirm that I'm speaking to Edward?
Yes, yeah, that's right.
And at this point, I confirm
all that,
details. And okay, Edward, my name's Dr. Gandhi. Just call me Ajay. I'm one of the ITU doctors here, looking after your brother. Just so I know that we're on the same page, can you just recount what was last spoken to you about your brother's condition in the hospital? Just so I can fill in any gaps or clarify any understandings.
Yeah, so I got a call a couple of days ago from a very nice doctor, I think her name is Fatima, who told me that Andrew had been in hospital for almost a week, but that you'd had some difficulty getting in contact with us, but fortunately you got us in the end. That Andrew was on intensive care, was on a breathing machine because he had a chest infection. That I think that she said that he'd had a fit in the first instance, and that there was some sort of worry about the scans or something. But my impression is that sort of, I mean, I've not been able to come in and see him because I've got COVID myself at the moment. But I'm hoping that the chest infection and things are starting to get better. He's had a couple of more days on the antibiotics, and that the fit and the worry about the scans and things are all kind of under control as well. How's he doing, Dr. Gandhi?
So I feel sometimes with these conversations, it's often easier to be quite frank, and that that I'm not beating around the bush when I speak to you. I hope you don't mind. I wish that I had better news to tell you, and I wish that I was telling you that your brother is getting better.
AJ, stop.
But
stop. Don't go into the next W until you just give us a chance to hear a response.
Oh yeah, okay.
But so I'm sensing that you've got something bad to tell me about how he's doing.
That's absolutely right, Ed. You've given a fantastic summary of what's happened so far. However, I worry that despite us holding all of the sedation, your brother is not responding in the way that we would hope. He is not opening his eyes himself. He's not able to communicate with us, and he's not moving any of his limbs in the way we would expect.
Okay. So you're saying he's in a coma, is that right?
I think that's a good way of putting it. And this is probably as a result of his stroke.
Okay. So you're saying that he's not waking up, but is that the drugs that you're giving him?
I wish that it was, in fact, as a result of some of the medication we were giving him. However, we have stopped all of those medications, and we've stopped them for some time. So we can be confident that it's not our medication which is stopping him from responding to us or showing us what he can do.
I break that news. I worry, therefore.
I worry that the stroke he's had is so severe that this may be something that he may not survive. And
Wow. Okay. I mean, I know, you know, I know people who've had strokes in the past, and you know, it's taken a long time, but they've got better from them. You know, they might not have been perfect. You know, their speech might have been difficult or something, but I mean, why can't that be the case for Andrew?
so there are many types of stroke, and the majority of strokes are often things that can be recovered with time. However, in your brother's particular case, he's had a very severe stroke, which we can see on the CT scan. And that shows catastrophic damage to the tissue of his brain. Long story short, and in summary, regardless of the pictures that we see, your brother is an individual, and the important thing that we are not seeing is any recovery from him, which we would expect at this stage. And it appears as though his stroke is so severe that he is unlikely to wake up, to talk, or to walk on his own again.
Wow.
And I'm sorry to be the person to have to bring this up, and I can imagine this has come as quite a shock to you.
Yeah, quite. I mean, you sort of.
Right, I'm going to stop you a second there because I can see you trying to work out how to help. And I think now I would like to suggest if we just give Ajay, so I wonder whether, go on to the third. You can't break this bad news anymore.
Yeah.
You now need to move on to the I wonder whether.
I wonder whether your brother has ever that's divorced, isn't it? What would matter? I wonder
whether it would be helpful to think about how best to look after him.
Yeah, I wonder if it would be better. It would be worth thinking about our method of looking after him, or how we can make things better for him.
Yeah, okay, that makes sense.
Your opinion, and obviously you know him better than we do. What do you think would matter to him?
Knowing this context,
Knowing everything I've told you and how severe the stroke is.
Well, I mean, I think it's not something we've ever talked about directly, but I mean, I know he's a stubborn man. He's very, very independent. It's kind of one of the reasons why we didn't worry too much when he sort of disappeared from the WhatsApp groups and all the rest of it for a while. You know, he just does that. He goes and does his own thing. I mean, he doesn't even like going to the GP when he's got a problem. He doesn't like being told what to do. He very much knows his own mind. And are you saying that with this stroke, I mean, could he improve at all? I mean, could he get back home, for example? Is that possible?
I think in medicine we often try to give you black and white situations where possible. And unfortunately, in this situation, I think, in my opinion, and with consensus from our colleagues from the stroke team, that this is not a stroke which is survivable if we were to take away the machines we are using right now to support his breathing and his blood pressure.
Wow. I mean, I remember when we were quite young and there was...
Mike, I'm gonna, you would get an Oscar for acting here, Mike. You absolutely would. But for time again, because we want to focus more on the job for AJ. I'm just going to stop us for a second. AJ, how's it feeling for you?
It's good, actually. I feel like I'm definitely guilty of using more of the oxygen in the room. So I think this is a good practice to just say short
Chop and chunk. Your own words, yes.
Listening and getting a feel from your head.
And how's it feeling at the moment?
I feel like it's making progress, but me not making the progress with a hammer. It's
letting him process it. Yes, because you're being compassionate. What do other people think? What do you like about what you've seen from AJ and those who are online? I know you can't see it necessarily, but what you're hearing, what do you like?
I think it feels like Edward is leading the conversation, which is quite nice. He kind of stood by what he's giving you as opposed to just your own agenda, trying to get that.
Yeah. We haven't heard AJ's agenda yet. You know, if you ring up to think we need to stop treatment and we need to stop not resuscitate him, you know, given Edward any of this preparatory time, you haven't shown any compassion. Whereas I think Edward knows this doctor cares about his brother. I think Edward knows that he can trust AJ to do what's right. We haven't yet got to what is right because Mike was still helping us see that Edward might need quite a bit of time, and it's okay if this becomes a bit, you can see you can't make decisions now. You could say, perhaps I want to ring you tomorrow. You could think of what questions you want to ask. You don't have to get it all in one because this is a process that Ed's going through. On the other hand, if you did need to, there are times when you have to possibly intervene a bit more, AJ, because Ed was taking so long to process, and you might need to make an urgent decision, that you might need to force it. From what you're saying, it sounds to me like Ed's independence is important. Ed's ability to be at home on his own is important. I don't think that's going to be possible. Given the scenario that he may well die, I'm wondering what would matter to him. And so you take a little bit more control over it, but the same process, those words might help you in your delivery of that process. And then you do, so what I know, and we probably haven't got time today to go through that, but you then end up with so what are the plus ones? Yeah. And
so focusing on comfort, I think we perhaps suggest that
if he were to survive, when we turn it off, we can see if it's possible to get him into a place that's more like home, or possibly even if he does surprise us, get him home, because home seems to be important to him and his independence is important to him. And you know, Ed might be religious, and so you might want to introduce him to this. You know, you sound to me like you're a man who might believe very strongly, and of course, if you do, then feel it's okay to pray for him, you know, so that he feels he's doing something too. Might be important. Because of time, and I suspect people have. Yeah, go on, AJ.
I wonder, because you brought up faith quite a few times here. I'm not necessarily a religious person. I would say I have some faith, but I'm not a religious person. But I was brought up as a Hindu, and I just wonder phrases like that, like you can pray for him, or I wonder if in your experience it's ever come across as contrived. I'm not saying it is. Yeah. I think it's okay, but I can see some people, especially as more and more people move towards atheism and being agnostic, is that ever seen as something, or you've ever felt might come across as contrived? Is there a good way to use faith? Because the majority of patients do have.
So I think you probably have to ask people of faith that. Yeah. My experience is that actually people believe so strongly in something that you recognising it is important to them. You know, a lot of the Judeo-Christian religions use the term God willing. And if you're a devout person, God willing means that you recognise that. It doesn't necessarily mean that you believe it. You know, I can say God willing. I know for you, you're a person of faith. God willing, you'll get better. I'm not saying I believe it, and I don't think they think I'm contrived or whatever. The Islamic faith uses the term inshallah. And I think it means roughly the same thing. It's recognising that we as doctors have a certain humility and that we can't control everything. And I do use the word. In fact, if I see a patient who is clearly devoutly Muslim, I will say, I'll walk in and I'll say, Salam alaikum. And my experience is they appreciate that because they know that I'm grounding myself in what's important to them. And I will use the word with a certain hint of, I know I'm a bit of an imposter saying it, but inshallah, I know inshallah you would wish that your prayers will be heard. And I'll use it because I'm helping them to know that I understand the pain in the context of the way that they are. And tell me if you think that I'm being, I mean, I shouldn't look at you, but I know you're clearly, your faith is important to you. And my experience, and I can only talk about my experience. Yeah. Interestingly, previously when I've given this talk, and I have talked about this because I think in this particular part of where we practice, we have so many different faiths that we do have to work within that. One person said they did think it was a little bit of an assumption for me to use the word inshallah. Yeah. I personally have never had any patient or relative tell me that. Yeah. But a doctor who I was teaching did say they weren't sure if that was comfortable. So you have to do what you think is comfortable. Yeah. My intention is not to be patronising.
I suppose as long as your intention is contrived, then it shouldn't come across as that.
I think that's right. And you can say I'm not a religious person, but I can see you are. Yeah. And so from you, I hope your prayers are heard.
Sorry. I tend to find quite helpful.
Go on, Mike, sorry.
I tend to find that reflective language is quite helpful. I think if you sort of bring up the subject of religion, sometimes it gives permission for people to then talk about something which they might feel we don't care about, it's not relevant, it's not medical. But actually, if you bring it up, it allows people a chance to say, well, actually, this is important to me or this is important to them. And then if they use language such as, inshallah or God willing or whatever it is, then I think that that's then okay for me to use. As long as I'm kind of acknowledging that as this is what you believe, this is how you are approaching this situation, and I completely respect that, and we're on the same page on that. It's not that I, believe the same thing. It's not that I share the faith with you, but I recognise that this is really important to you, and we're going to take that into account in our decision making. We're not just going to brush it under the carpet and go, that's just that religious guff, isn't it? Keep it for the temple.
Yeah.
I think there is no shame in directly asking the question of, do you or your relative has any particular spiritual or religious tendencies they would want it to be maintained? And I've never found anyone, they either say yes or no.
Fatima, I think you're absolutely right. And I'd add one other thing. When people say yes, what we tend to do in healthcare is say, would you like to see the chaplain? That is such a Judeo-Christian patronising response. I'm brought up as a Jewish person, but it's having a rabbi, having a priest by the bedside is Judeo-Christian. For Muslims, I don't think they ask the imam to go by the bed. They would listen to the Quran, I think. And that's my experience. And so, actually, if you say to them, would you like the chaplain? They'll say no. But if you said, as you did, is there anything that would be important to him? Yeah. They might say, would you be able to put some an iPlayer next to him so you can listen to some Hindus don't ask the person from the temple to come and pray with, but they might like bhajan or some holy water or something. Again, what was lovely about what you said, Fatima, is that you give them the open question. We don't just think they're religious, call the chaplain. It's the same number of questions. What would be important to you is, would you like the chaplain? It takes just as much time, but it's more useful.
It's like you find like name is like a Muslim name, but they still they are not practicing, and it doesn't matter for them. And when you bring it that way, it's a bit of makes them like feel like shame. It's not a nice way to tell someone who you suppose he is Muslim, but he's not.
Yes, correct. And so it's about what does it mean to them. And you know, there are many people who have a Muslim name and are devout. There are many people who are Muslim name, aren't devout, but they're still culturally Islamic, and they'll do things that they want. And there are many people who are Muslim who have rejected the whole lot. It's not for us to judge, it's for us to find out which they are. I think I wanted to offer you that today as a vehicle to see would it help you. Mike, did we have a couple of sort of evaluation questions?
Indeed. Let me just.
AJ, would you be able to is there a slide? How are you doing this, Mike?
I will just pop up the slide.
If you go back into, is it still on the Slido as another thing?
Yep. So I think that's the next one.
Just fill in, if you can, or on your phones. If you've got your phone on you, just pull out Slido. And thanks. And then the other thing that we would like to do is, if there's a volunteer amongst you who would be willing to, we want to try and find out who's on the session, which we should be able to do from the recording, and then find out in maybe 2 or 3 weeks' time what your experiences are, whether you found an opportunity to test the tool, and whether it had, what the impact of testing it has been. Would you be willing, if we do contact you in a couple of weeks' time, to let us know?
So Caval has agreed and has volunteered to be the person to contact, and it will, if you wouldn't mind letting Caval know that you wouldn't mind us contacting you in a week or two's time to get your thoughts on the session and how you found it in practice, how you found your experience of this.
We'll give Caval, if you could contact me, and we'll identify 2 or 3 questions. That's all it'll be for people to let us know about the impact of using it in real life.
Yeah, I can definitely do that.
Thank you. See Daniels1 at nhs.net.
Sure. I'll put my email on the WhatsApp group, and yeah, just let me know, and we'll go from there. Thanks, guys.
Three out of three so far.
4 out of 3. 4 out of 4.
Thank you, everyone. We're
So,
learning as we go, so I hope it's been useful for you.
Like when it's the same scenario basis, or do you that be practical?
Are you saying patients still ventilated?
It's ventilated, but we don't actually bring it, so you say they're dead.
So what's the
That's all I to.
Right, guys, we will call it a day there. Thank you very much for your attendance, and let Caval know if you're happy to be followed up.
Can you say that to Mike?
I'm sorry, I didn't hear who spoke.
That again. Did you say something?
I just said thank you very much for your attendance. Let Caval know if you're happy to be followed up, and I hope that everyone's found it useful.
Yeah, thank you. I am happy to be called up.
Brilliant. Just drop Caval.
Yeah.
Cool. Thanks, Fatima.
Mike, will you
Thank you.
summarise the Slido and send them to me?
Will do. Absolutely. Yeah. Charles, thank you so much for that. Really, really useful.
Pleasure.
Cheers. I'll speak to you later.